We always like to let you know, just in case you have comments or questions, please don't include any personal health information in those comments or questions. We would appreciate that. These do live on our website as well as typically our Moodle online platform. So welcome today. You can see on screen we have some information on how to mute and unmute yourself. If you're not on video, you can start your video up. If you do have a camera hooked up, of course. Looks like I'll need that. There we go. All right. Sorry about that. All right, great. Giving us some very important information on our screen right now that you can't see. Sorry about that. All right, so if we do call on you, we do know who is on at the moment. And if we do call on you, feel free to stay passive if you don't want to speak. So more icons on how to mute and unmute yourself. Our disclosure and accreditation statements are on screen right now. And we do partner with Molina and Blue Cross Blue Shield for a number of our sessions. We do case consultations. You can be reimbursed for those. So if you're interested in that, typically for our Adolescent Health Initiative, which will be starting up in about a month, you can bring your cases to us and be reimbursed by Molina and Blue Cross Blue Shield. It's up to $150, so it's worth the time to take to do that. And at this point, we'll go ahead and unmute yourself and let us know that you're out there, where you're from, and I can mark you down as present. If you don't, for some reason, have the available microphone, or if you're not on the phone, you can use the chat box as well, and I'll say hi to you all momentarily.
This is Maria Otero with Nuestra Salud, a community-based organization that works with the Spanish-speaking community in New Mexico.
Hi, I'm Maria Otero.
Hi, I'm Sophie Peterson. I'm one of the physician consultants for the New Mexico Breastfeeding Task Force.
And Sophie Peterson can just make you out there. If you can speak up just a little bit, that'd be helpful. Anybody else out there?
This is Heidi Ferdine from the New Mexico Breastfeeding Task Force.
Hi, Heidi.
Hi, Heidi. Okay, and this is Kevin Worling here at Envision New Mexico Systems Analyst, and we'll go ahead and go down around the room, starting with Elena.
Elena Scher, I'm with Envision New Mexico.
Maya Trillo, and I'm with Envision New Mexico.
Hi, good afternoon. Courtney McKinney. I'm with Envision New Mexico.
And hi, this is Adrienne McConnell, and I'm also with Envision New Mexico. And I'd like to thank you all for joining us today for our telehealth session. Today's session is sponsored by the W.K. Kellogg Foundation, and it's part of a collaborative project to increase support and care for breastfeeding moms in New Mexico. Today's session and all of our sessions are going to be housed on our website after we're finished, and you can go back and review those at any time. Just to let you know, though, if you're not watching this live, then you will just be receiving partial C&E credit. And I just wanted to let you know that after the telehealth session today, we'll be emailing you out a survey, and these surveys, it'll just take a few minutes to fill out, and they're very valuable for us to collect information on your thoughts about today's webinar, how the technical aspects went, and that type of thing. So if you wouldn't mind doing that, that would be great. And now I'd like to introduce today's speaker, Dr. Emily Sebesta. Dr. Sebesta graduated from the Johns Hopkins School of Medicine in 2001 and completed her pediatric residency at the University of New Mexico in 2004. She is a professor in the General Division of the Department of Pediatrics at the University of New Mexico and has co-directed the Mother, Baby Unit, and Newborn Nursery since 2010. She's been instrumental in improving support for breastfeeding mothers, including spearheading the effort to make UNMH a baby-friendly designated hospital. She is the American Academy of Pediatrics Chapter Breastfeeding Coordinator for New Mexico and has worked with the New Mexico Breastfeeding Task Force for many years to help support breastfeeding families and provide breastfeeding education to medical providers. Welcome, Dr. Sebesta.
Thank you. Thanks, everybody, for being there. Hi to all of you I know. So this topic today is breastfeeding and maternal medications and contraindications. We've heard from a lot of folks that these are issues that a lot of providers are having difficulty with, so we wanted to talk about it. Let me see if I can figure out how to actually do this.
Click right.
Okay. So our 3 objectives today are to understand a little bit about the basics of drug transfer into human milk. Don't worry, it's not going to be too much pharmacology. 2, probably the most important thing is to know where to look and who you can talk with when you have questions. 3, learn about some of the most common contraindications to breastfeeding, of which there are not very many. And let me interrupt myself real quick and just say I welcome questions, I welcome interaction. It's a little bit hard for me to do this without making eye contact. So if anybody has any thoughts or questions, I would be delighted. Oops, sorry.
Right on the screen.
So case 1, we have Eileen. She's 34 years old, and she has a long history of depression treated with sertraline, commonly called Zoloft. She tried discontinuing at 4 weeks when she found out she was pregnant. However, she resumed taking it at about 20 weeks when she had a relapse and had severe depression and suicidal ideation. So she's been admitted to labor, and she wants to know if it's going to be safe to breastfeed her soon-to-be-born son. She also has migraine headaches, allergies, and asthma, and wants to know if she can go back to taking her ibuprofen and if it's going to be okay to use loratadine and albuterol. Oh, sorry. Why? Okay. So just a quick graph to show medication use during pregnancy has gone up a great deal since the mid-1970s. I'm sure it may have gone up even more, but you can see that we're having to deal with these questions more than we ever have in the past. So resources to look up drugs and medications. There's really 2 primary resources, and your lactation specialist, if you go to talk to them, are going to tell you that. LactMed, which is online, and Hale's Medication and Mother's Milk. I'm sure most of you have used LactMed before. So on your left, you can see this is what shows up when you pull it up on your computer, and over here is the screen that you see when you get LactMed on your phone, which is free. So I actually pulled it up on my phone recently, and I'm not very technologically savvy, and it was extremely easy, and I now have it on my phone. So I highly recommend, this is probably the most up-to-date of all the sources that you can go to. So this is my go-to for any kind of topic on medications.
Emily, can I
Yeah.
do you have to have credentials to have that app
No.
or to access that? Okay.
No, LactMed is part of the NIH.
Okay, just
and
make sure
it's,
everyone
anybody can get it. Moms can get it.
Okay.
Anybody can get it. Medications and mother's milk is kind of what was previously the gold standard and is still a really important tool. So I'll often look at both of these sources when I have questions, especially when a mom is on quite a few medications. Checking both kind of makes you feel like you've covered all your bases. And the most recent book is from 2017. So what if LactMed or Hale didn't have any information? So first, I just want to say that this is a quote from the American Academy of Pediatrics, and I think we've all seen this, that many mothers are inappropriately advised to discontinue breastfeeding or to not take essential medications because of fears of adverse effects on their infants. And I think this is kind of just that fear of litigation, or we're a very litigious society, or just fear in general. People think it's easier to just say stop breastfeeding or don't take the medication, but that is not a good answer. First of all, few medications are contraindicated and very few will have any adverse effects. Unfortunately, information for providers is often lacking. So real quick, medications with absolute contraindication for breastfeeding. This is it: radioactive iodine and chemotherapy. It's pretty much the only 2 that are really absolutely contraindicated. Radioactive iodine can increase mom's risk of thyroid cancer later in life, and can also increase her risk of breast cancer. So she needs to stop breastfeeding for several weeks prior to doing this because it likes to go to active tissue. Radiation therapy is actually okay unless it's being directed at the breast for breast cancer, in which case it may decrease the breast milk supply. Classes of drugs to generally be avoided but not absolutely contraindicated. Amphetamines, I don't think any of us would think that was a good idea. Although I have to say, I looked it up, and breastfeeding infants of moms who took amphetamine for narcolepsy grew fine and there were no adverse effects. ergotamines, which are commonly used for migraines. You can get tachycardia, vomiting, diarrhea, and there's alternative agents that are available. And statins, there's no proven data, there's no evidence that it's actually caused harm, but the concern is that it would disrupt infant metabolism. But again, there's no data. So there's going to be new FDA labeling requirements. I haven't actually seen any yet, although this passed in became effective June 30th, 2015. So new labels for medications that are new on the market are now going to have to get rid of the letter classification. You may remember A, B, C, D, which were extremely unhelpful. And they're going to have clinical considerations. There will be a risk-benefit statement, ways to mitigate exposure, effects of the drug on milk production, and they're even going to have a section on females and males of reproductive potential, as well as pregnancy, of course. The problem is it doesn't apply to non-prescription drugs, and it doesn't apply to prescription drugs that were approved before June of 2001. The FDA has encouraged voluntary compliance, but we know how that goes. So general considerations when you're thinking about if the medicine is safe or not. So one is the medication safely used in infants. So a good example is fluconazole. We use fluconazole in infants who have invasive yeast infections. So it is okay for the mom to use it if she needs to. 2, how much of the medication is actually transferred into the breast milk? 3, what is the bioavailability? In other words, if a baby drinks milk and it has even high levels of the medication, will it get absorbed into the baby's bloodstream? And if it doesn't, then there's no harm, there's no concern that it will affect the baby. What is the half-life? Is it going to be sticking around for a really long time? And is the medication lipophilic or hydrophilic? In other words, does it love fat? If it loves fat, it's going to concentrate in breast milk. So when determining how much of a drug is going to actually pass into the milk, the 3 most important factors are, and I'm going to fly through this, volume of distribution, protein binding, and molecular weight. So volume of distribution, this is when it's handy to have everybody in the room. So if you're looking at me now, volume of distribution, so if there's a big volume of distribution, then the drug is going everywhere throughout mom's body versus a very narrow space. So big volumes of distribution are good because it's less likely to concentrate in milk. Protein binding, more protein binding is good. So if it's binding up to a lot of mom's proteins, it's not going to be available to go into the baby. So over 90% is considered compatible usually. And molecular weight, again, if the drug molecules are very, very big, they're going to have trouble diffusing across the milk, the barrier with the blood. So there's going to be less into the milk. And over 800 is the best, less than 200 is going to pass easily in. And as you can see, there's a great big gray zone, 200 to 800. So other considerations, Tmax, when is the drug going to be highest level in the baby or in mom? Milk to plasma ratio. So how much is in the milk compared to mom? So less than 1 is good. You don't want there to be more in the milk than there is in mama. Relative infant dose is just looking to see how much of mom's dose is basically in the baby based on weight. So less than 10% is considered generally good. And all of these things you can find when you look up. I think Hale has more of this than LactMed, but I know Hale has more of this than LactMed. So tips for reducing a baby's exposure. Well, don't nurse at the peak concentration and administer the drug before the infant's longest sleep period, because that's really hard when they're brand new because they eat all the time. But as the baby gets a little bit longer, if you know the baby's going to sleep for 5 hours, then mom can take her medication right after she feeds and before that 5-hour period. So examples from our case, albuterol. So I'm just going to skip down to here. Oh, here we go. Low bioavailability. So it's not going to end up being absorbed by the blood. Okay, even if some gets into into the milk, the baby's not going to absorb it, so it's totally fine. Ibuprofen, very low levels in breast milk, very short half-life, and we use it in babies, although we don't use it in babies less than 6 months. So this is actually considered a preferred drug of choice for pain in mamas. So let's back up and try to use our newfound pharmacologic knowledge to look at sertraline. Okay, so the volume of distribution is greater than 20. And this is when I usually like to have audience participation. So good or bad, answer in your head. And the answer is good. This is high. Protein binding, 98%. I'm gonna pick on you, Adrian. Good. You said good. Good. Adrian says it's good, and she's right. All right. Molecular weight, 342. I'm not gonna pick on anybody, but good or bad? This is equivocal. That's a net gray
That's a
zone.
trick question.
That's in the gray zone. Well,
To an 8.
this is what the molecular weight is. It's in the middle.
So what do people do with that? Huge, and that's a huge gray zone. I feel like.
Well, because that's why you look at
the other
lots of
things.
different things,
Okay.
right? Because rarely are you going to have everything
Just
be
look
good.
at that.
Log P, I'm going to skip that because I never can remember what log P means. It's lipophilic. It likes to concentrate in the milk, so that's bad. Okay. Half-life 13 to 45 hours. That's kind of a long half-life, so you're going to have a hard time dosing it. On the other hand, it's really good for mom that it has a long half-life because it's going to control her depression. Milk to plasma ratio 0.42 to 4.8. Equivocal, right? Less than 1 is great, over 1 not so good. Relative infant dose 0.2%. What do you think? 0.2%. Teeny tiny. That's good.
Okay.
That's very good. Okay. So yes, we were correct. If you kind of put all that together and did a balancing act, you'd say this is probably okay. And according to LACMED, this is considered to be one of the preferred antidepressants during breastfeeding. And in fact, I'd say it's number 1. HALE listed as L1, which means it's safe, in the safest category, compatible. And, nonetheless, they say monitor for sedation or irritability, not waking up to feed or poor feeding. But I'm not seeing this. So just real quick, you're going to see this a lot. That's why I use this as an example. So lifetime prevalence of depression is very high, 16%. Most commonly used drug for depression is SSRIs, and up to 3% of women are taking an SSRI. So you're gonna see this. So ignore all the small print. Just notice that the only ones in blue, the only ones that are considered preferred in the SSRIs and the SNRIs are sertraline, Zoloft, and Paxil. Paxil can have some issues in pregnancy. Looking at the relative infant dose, smaller in sertraline. So sertraline pretty much is the preferred. Prozac, not so much. Okay, so you actually discourage it. So if you've got a mom who's pregnant, Sophie, you'd probably want to switch her from Prozac to sertraline. Whoops, sorry. So keeping on going. So you encourage Eileen to breastfeed her son. She has a C-section, gives birth to a nice term 3,800 gram boy who's pretty jittery. She also had diet-controlled gestational diabetes, and her glucose is 44. And I'm sorry, I just like to give clinical cases a little bit. So what could be causing her son to be jittery? Any thoughts? Anybody out there want to?
Is her mom on antidepressants?
Yeah, this is Eileen. You told her to breastfeed. She's taking the Zoloft. So she's taking Zoloft, and she has gestational diabetes, and the glucose is 44. So probably not the glucose. 44 is actually okay for a brand new baby. It's probably the serotonin. So there is something called serotonin reuptake inhibitor related symptoms. And I know we're talking about breastfeeding, but I think this is important to mention because you're going to see it, and it's going to tie into breastfeeding in a minute, of course. But basically, babies look like they're withdrawing from opiates. They have tremors, jitteriness, irritability, excessive crying, sleep disturbances, feeding problems. So they act like little NAS babies. This can occur to 30 to 64% of babies who are exposed to utero. So you're actually going to see this quite a bit. Things that are going to contribute are maternal dose, which SSRI are you using, individual drug clearance, genetic predisposition, prematurity, so a bunch of things you can't control. Symptoms are going to occur within 2 days and are usually self-limiting. This is important for practitioners because if you've got a mom, you've got a baby doing this, before jumping to assuming that mom's using an illicit substance and scoring the baby and, God forbid, giving them methadone or morphine, if the mom is on an SSRI, think about this and it's going to go away. So 2015 study looking at antidepressants and poor neonatal adaptation, which this is also called sometimes, said formula feeding increases the risk. Dosage did not. In other words, you want these babies to breastfeed. It's going to reduce their risk of having this syndrome, just like it helps reduce NAS. Okay, case number 2, marijuana, everybody's favorite thing to talk about with breastfeeding. So you have Valerie, she's 24 years old, she's pregnant, she's en route to California when she gives birth to a late preterm baby, 36 and 2/7 week. And when you ask, she says she smokes a little pot now and then, but says she doesn't drink or use any other drugs. Naturally, it's Saturday. You cannot access her records. Nobody's in the office. So we're seeing more and more of this. This is a New York Times article. Ooh, I don't have, oh, there it is, February 2017. Pregnant women turning to marijuana, perhaps harming infants. A lot of women are using marijuana for nausea during pregnancy. So 2016 meta-analysis looking at 24 studies, looking at prenatal effects of marijuana, found maternal anemia, decreased birth weight, kind of like tobacco, and increased NICU admissions. So again, not breastfeeding, but we think it has an effect. There's a whole bunch of words on here that I'm not going to go over, but the risk of marijuana use during pregnancy, this was a JAMA article. And the thing I want to kind of focus on is, one, the endocannabinoid system we have receptors for endocannabinoids in our brain. So we are geared to respond to marijuana. And this prospective study found that not only did the babies have fewer growth restriction, but they had increased frontal cortical thickness later on in life if they were exposed prenatally. So in other words, it changes the brain. Now, granted, this is in utero, but that's one of the problems with looking at drugs and medications or drugs in lactation, is that most people are not going to start smoking marijuana or taking Zoloft for the first time, although sometimes with postpartum depression. Many of the exposures they're going to have had are going to have had occurred in utero as well as extra utero. So just as a kind of precursor. And this, I like this graph because it talks about the correlation between perceived risk and use. So 1970s, the perceived risk of marijuana was very, very low. Use was very high, not a surprise. Over the years, our perceived risk of marijuana went up, use went down. So now what's happening? Perceived risk of marijuana is going down as we legalize marijuana. It's probably going to continue to go down because more and more states are legalizing it. That means use is in all likelihood going to continue to go up. Okay. This is interesting. You know, daily cigarette use has gone down over the years. Marijuana has gone up. It kind of stayed steady, but again, I wouldn't be surprised to see that going up. Okay, so her UDM is positive for THC, but nothing else. And she's really upset because the intern who delivered her baby told her she couldn't breastfeed her baby. So the question I have for you is the intern correct? And what would you recommend? I'm just going to move on because it's not a live audience. Okay. Then I'll talk about what I would do. So trends in marijuana use among pregnant women is gone up. That's not a surprise. So 4% of pregnant women using marijuana in the past month. That's a lot. And almost 8% of reproductive age women who are not pregnant. So again, you're going to see this a lot. So looking at whether or not you would consider letting this mother breastfeed. So the pros, protein binding is very, very high. Okay, volume of distribution is pretty high. Predictive relative invidose is pretty low. On the other hand, marijuana is very lipophilic. It likes to store in the fat cells. And this is the take-home point for marijuana. Milk to plasma ratio can be up to 8-to-1 in heavy users. In other words, the baby's going to get 8 times the dose that mama's getting, or at least 8 times the amount in the milk, if she's a heavy user. Now, nobody defines exactly what a heavy user is. If you look in the literature, probably daily is heavy use. So we'll talk about that. Long half-life, also bad. So it's going to store mamas and babies in the milk. Babies are going to end up with really high doses because of that and because of the long half-life. So AAP has talked about marijuana. On the one hand, they say substance abuse not a categorical contraindication. On the other hand, they say contraindicated. Only one report in the literature of an adverse effect of marijuana on a nursing infant. Effect not mentioned. So there's really very little data, and that's what I'm trying to get across here. LactMed said, there's one study that said maybe result in motor delay at 1 year, but occasional use has no discernible effect. And this is what I like. I mean, basically they say it should be minimized or avoided, right? But it's preferable to encourage moms who use marijuana to continue breastfeeding while minimizing infant exposure and reducing marijuana use. And I think this is the bottom line, is that you have to kind of make a judgment call on the specific case that you have before you. How well do you know this mom? What leads you to believe she's going to use a lot? What leads you to believe she's not going to use a lot? And then you have to make a decision. Hale comes out and says increasing concern, strongly discouraged. But then again, he says for single or frequent exposure, you can continue after 24 to 48 hours, although I'm not really sure that makes a lot of sense because it is concentrated in the milk. And again, for daily continued use, moms should not breastfeed. And I agree with that. This was a nice article that said basically each institution should work towards a policy of ensuring the best practices for their particular population of cannabis users. And again, continued cannabis use may outweigh the negative side effects, or breastfeeding may outweigh the negative side effects. especially in infrequent users. So where we came out in our guidelines that we created were moms with a history of occasional use of alcohol or marijuana and either quit when they discovered they were pregnant, continue to use but small amounts and not every day, and they either plan not to drink or smoke while they're breastfeeding or plan again only to use small amounts and not every day, then we support breastfeeding. So, and again, and this we put in our document specifically because a lot of people, a lot of hospitals, a lot of social workers feel like you have to call CYFD. So we specifically added a statement, actually it's not here, saying you don't necessarily have to call CYFD. But again, positive screen at time of delivery shouldn't alone preclude breastfeeding if you have reason to think that the mom's use is occasional. And you have to document your reasons, and you've got to counsel mom. And I think this is the most important. This is the second most important, because whatever we say, moms are with us in the hospital for 1 or 2 days. They're going to go home and they're going to do exactly what they want to do. So the most important part of our job is to talk to them about why we think it's not a good idea if they're going to start smoking a lot of marijuana at home or taking it every day. I actually had a recent case like that where the only thing that would control mom's headaches that she sustained after a traumatic brain injury when she was a teenager was edible marijuana, and we had a long conversation, and I think she understood and made a decision to cut back, knowing darn well that if she couldn't control it and had to go back to using marijuana, she would need to stop breastfeeding. Just looking at some other policies to give you a sense of how all over the map this is. University of California, San Diego says no need to discard the milk, no need to test the milk, and no need to have moms refrain from breastfeeding. Stanford doesn't have an official policy. One of the California hospitals, and I don't remember which one it was, told me they don't test for marijuana. It's not on their UDM. The UDM specifically excludes marijuana because they don't want to know. Austin says discourage it. Denver Health has a nice handout about marijuana and your baby and strongly advises against it, which is essentially where we come out. We just go a little bit further in stating there are going to be exceptions and you really have to individualize your care. And again, you've got to counsel and document. Okay, so you tell Valerie you support her decision to breastfeed conditionally, and you're going to contact her prenatal provider tomorrow for more information. So why do you do this? What if she'd been smoking every day? What if she was lying? Well, you don't make very much milk in the first few days. It's colostrum, which doesn't have a lot of fat. It's pretty safe to allow her to breastfeed at this point, knowing that you may have to change your mind. So on Monday, you reach her doctor, you get prenatal records, and you find out she had her first visit at 8 weeks. So she had good prenatal care with a total of 11 visits. And they did obtain UDMs because she had told them she used marijuana occasionally. And all of her UDMs, except for the first one, where she had just found out she was pregnant, were negative. So including one 2 weeks ago. So with this information, you enter an order, put your note explaining, and you support her decision. Any questions about that? Any disagreement? This is probably the most controversial thing you'll run across with breastfeeding and substances.
The information in the research about the school-age children, that their brains had developed a little bit differently, did they indicate any cognitive repercussions for that?
That's a great question, Adrienne. So the question was, did they see any cognitive deficits? That study didn't talk about it, but there's another study that shows that teenagers who use marijuana daily lose 8 to 10, on a long-term basis, or I don't know how long, lose 8 to 10 IQ points. And so I think the take-home message is that the developing brain is very sensitive to marijuana, and there's physical changes, and that's what that article was kind of so startling at. And in the cases of the teenagers whose brains aren't forming nearly as fast as an infant's, you lose IQ points. So you can imagine if a brain that's developing slower than a newborn's has that kind of a hit, the daily use for a baby could really lower their IQ. And as the mother of 4 children whose IQs are all over the map, I can tell you, you want those 8 to 10 IQ points. Case number 3, so opiate replacement therapy, also another big topic. So Rachel's 19 years old. This is her second baby. She's got a history of polysubstance abuse. She started using oxycodone and other pills when she was 14. Then she turned to heroin when those got too expensive. She had her first child when she's 17, but that child is not in her custody. When she found out she was pregnant this time, she sought help. She got started on buprenorphine and got prenatal care at the Milagro Clinic, which is a clinic in town that specifically works with mothers who are using substances during their pregnancy. So she's just delivered a term AGA girl. And I'm going to back off. So here's the epidemic of maternal opiate use. This is why we're talking about this. So use of opiates before pregnant, while you're pregnant, have gone up hugely, and they're still going up. Okay, so this is comparing 2000 to 2009. We all know from the press and our own experience, it continues to go up. So what do you know? Neonatal abstinence syndrome is also going up, same amount. This is a busy slide. This is methadone. This is morphine. This is hydrocodone. This is oxycodone. So drugs that you can get on the street, use has gone way up over time. Okay. And then back up. Can I back up? How do I back up? Clear away.
Just use the clicker.
Oh, previous. So methadone has stayed steady and actually gone up a little bit because people are, seeking help. But this is when our crisis really started, when everybody started saying we're not addressing pain well enough, we need to be doing a better job, and people started doing a better job at addressing pain, and as a result, we ended up with a lot more addiction. Whoops. So here is heroin use. So heroin use was really going down from the 1960s really nicely till about, hey, what do you know, right when we started prescribing a lot of opiates. So then here's prescription opiates starting to go up and peaking around here when, again, this is the time where we said we weren't doing enough. Those are starting to come down. Heroin's going up. This is because these are very expensive and this is very cheap. And this is men. It's come down and it's continued to go down. And this is women. So this isn't a real issue for our population. Possibly you saw this in the New York Times back in 2011. This has received a lot of press. I don't know, I read a New Yorker article recently that was very disturbing. This is a problem that's going to be with us for a long time. So our experience is we get about 180 babies per year born with mothers who had chronic opiate use, and every one of them's got to stay for 96 hours to watch for neonatal abstinence syndrome. Our numbers have doubled in the past 3 years, and actually this slide was based on data from 2 years ago, I believe. So that at that time we were having 6 to 7% of every newborn at UNM was opiate exposed. I think the number's probably higher now. So opiate replacement therapy and breastfeeding. So breastfeeding is encouraged. So if a mom is in opiate replacement therapy with either buprenorphine or methadone, and they're in a monitored drug treatment program, and they're not using other illicit substances or opiates. So mom's in a methadone program, but you find buprenorphine in her urine screen, that's not good, okay? Just because it's buprenorphine doesn't mean it's okay. It's got to be in, part of her program. And breastfeeding can decrease the severity of NAS. It decreases the chances of the baby requiring pharmacological therapy, and it decreases the length of stay. So we really do want moms to breastfeed. And this was not the case when I started practice. These babies didn't breastfeed. So Rachel's UDMs throughout pregnancy have been positive for buprenorphine, which she's supposed to be on. She had one UDM in the first trimester for positive for marijuana, THC, but otherwise everything's been negative, and she wants to breastfeed. So should you support her choice to breastfeed? I'm gonna let you guys answer this. What do you think? She's in a program. Her UDMs have been negative.
Yes.
Yes. Very good. So you encourage and support her decision to breastfeed. So they stay together. They room in throughout their 8-day hospital stay while her baby weans off. We do this a lot now. We board the mom, baby stays, they stay together, they get to breastfeed, they have skin to skin, babies get out of the hospital much faster. They're going to be seen in the focus clinic where they will have a team of pediatricians, family medicine, social workers, and developmental specialists. So we really try hard to help these babies.
Do you feel like, from your perspective, all those providers are on the same page in terms of breastfeeding? So the people from
Yes.
the program, the people from family medicine, do you feel like
Yes, they are
they're all
now.
on the same page?
They are now,
Okay.
yeah. And I think a lot of it is because a lot of the families from around the state end up coming to UNM.
Mm-hmm.
And so we have a lot of experience. And there's actually an effort right now to basically get those families back to the community. So training providers around the state how to take care of these babies and these mamas, because it's not the best care to take somebody from their home in Farmington or whatever and put them in the hospital at UNM. It's not necessarily the best care. So hopefully over time, we're going to have that's going to go back out to the community, but in a way where it's going to be done well.
If a rural community provider wanted more training on this, where might they?
So
what's the resource?
There is a initiative going on right now. Larry Lehman and Heather Pratt-Chavez. Heather Pratt-Chavez is pediatrics, Larry Lehman is family medicine, and they're actively working on a program, and that's going to be coming out. But for right now, I would say contact any of the people in this room who can then get you to Larry Lehman or Heather Pachambas.
We're going to be involved in the NOW project too.
Oh.
But I just wanted to see if there's any other.
Is that the same
specific-
project? I don't.
Yeah.
know. Okay, it may be. Okay. So yeah, not to my knowledge, but I think anybody could call the family medicine department or us, and we could talk you through.
Okay.
It's not rocket science.
So I
Although it
think
is
that's-
important to get your nurses trained really well so that you're appropriately treating or not treating.
Because I think that's one of the things that we're hearing from like the rural hospitals is like, who do we actually call?
Yeah.
Who can we?
Larry
You're in touch
Lehman,
with.
Heather Pachambas.
Okay.
Or me.
Okay.
So what if her UDM was positive for cocaine, PCP, or amphetamines? Well, we wouldn't let her breastfeed, right? And it's not so much we wouldn't let her breastfeed. We would discourage her from breastfeeding. And the bottom line, again, is that moms are going to go home and they're going to do whatever they want to do. So it's our job to counsel and explain in a way that is understandable for the mother and family members if they're involved, and to document that. So again, use of other illicit substances makes her a poor candidate for breastfeeding. And specifically, I want to point out that cocaine and PCP and their metabolites have very, very long half-lives and are considered to be really, really dangerous to infants. So if you had a mom who's positive for one of these, you want to sit down and tell her if she breastfeeds her baby, she could kill her baby. You want to be, it sounds horrible, but ultimately what we care about the most is protecting the baby. And so these two in particular are scary. Pain medications. So ibuprofen and acetaminophen are preferred. If you need to use a narcotic, these are the ones that are preferred, although I have to say, I don't think anybody ever uses this anymore, Stadol. Basically, you want to use the lowest dose for the shortest time. This came up at our MCH meeting yesterday because we typically, folks use, is it hydrocodone? It's hydrocodone, right? Yeah, hydrocodone. And even though that's not considered to be the best with breastfeeding, I think in small amounts for short periods of time, it's okay, and it's what we do. And again, you want to counsel the parents to keep an eye on how sleepy their baby is and think about how sleepy mama is. We had a bad outcome 5-6 years ago where a mom was taking Percocet at home for pain, fell asleep breastfeeding on the couch, baby died. So codeine and hydrocodone. So it wasn't hydrocodone, I take that back. It's not hydrocodone. Sophie, help me out here. Not hydrocodone, what is the one that we most typically use postpartum?
It varies a little bit from institution to institution, but generally we use Percocet, which has oxycodone plus Tylenol.
Oxycodone. Thank you. Not hydrocodone. Oxycodone. Thank you.
And hydrocodone is the one that's in lower tab, which is sort of honestly a second choice usually.
Right, and I apologize for misspeaking. Do not use hydrocodone, okay? Big red. Do not use hydrocodone. There are ultra rapid metabolizers. It's the P456, I believe, or P something pathway for metabolism. And for the ultra rapid metabolizers, there have been deaths. So you can get apnea, cyanosis, bradycardia, sedation.
So this is true for hydrocodone as well as codeine. I'd heard that about codeine, but not about hydrocodone.
No, that's codeine. I'm sorry. So codeine is the ultra rapid metabolizers, and hydrocodone is simply that neonates have a reduced clearance. So you're right, two different problems. Codeine is you can have the ultra rapid metabolism. Hydrocodone is just that babies stink at getting it out of their system.
Okay.
But either way, you don't want to use either one of these.
Well, so here's a question then along these lines, because obviously, people do a lot of C-sections these days. And so pain control in those first couple of days is usually a big issue for us. And not every mom responds well to Percocet or oxycodone. And we've been sort of vying away from codeine, which is like T3, right? Was a pretty commonly prescribed or used agent, even up to a year ago at our institution. And ibuprofen just doesn't cut it for some people with postpartum, or post-operative pain. I think I get stuck sometimes because I'm not sure what would be a second option to use, even though I think that our anesthesia does a great job. We have Duramorph now that lasts, through the first 24 hours post-op, which helps a ton. But I don't know what else to use in people who can't take oxycodone then.
I mean, I think one thing, I would say two things. One, they're in the hospital, and so you've got an added layer of protection that you have more people laying eyes on that baby, right? And again, the ultra rapid metabolism is rare. So even though we basically say you should avoid this, and if you look at the AAP statement on transfer of drugs into human milk, they say avoid it, but it isn't like everybody's going to have it too. There's not that much milk in the first 2 or 3 days. So while the mom is producing colostrum, it's probably a heck of a lot safer. So this is more of an issue for when mature milk comes in and you're starting to see bigger volumes. So I think if you, in those cases where the other medicines are not working for pain control immediately postpartum, that there's a little more wiggle room to use these drugs that we would otherwise be not so keen on, and just knowing that you're going to want extra attention. So, maybe Q4-hour vitals for that baby. And so maybe to have a conversation, if you as the OB are prescribing this medication, to simply have a conversation with your pediatrician and say, mom isn't responding to these other medications. I know we generally don't want to use oxycodone or hydrocodone for these reasons, but we feel like we have to. Can you monitor the baby more frequently?
And Emily, we have a question from the audience.
Yeah.
What do you mean by ultra rapid metabolizers?
So basically it means that it doesn't move through the system as quickly. Is that a good way of putting it, Sophie?
For codeine,
Yeah,
my understanding was that it
you don't clear it. You don't clear as much.
Yeah, the mom doesn't clear, and then the baby doesn't, they don't clear it in their milk, and so the more you feed the baby's dose I thought it was a clearance issue mostly with codeine, honestly, but it has to do with the way. Oh, you know what it is? I think it's because if she metabolizes it quickly, does it go into the milk quickly or something? And so the baby just gets these repeat increased doses.
I think that's what it is, exactly. So thank you, because I was trying to think about how to say it. It's one of those terms that you just kind of grow up with in medical school, and then you don't really think about it anymore. You just know it's bad, so I apologize. But I think that's right, that it's being metabolized very quickly and going into her bloodstream very, very quickly, and not getting cleared not as much as getting cleared through the liver or the kidneys, and is ending up concentrating in the milk. The best way I can put it, and I apologize if that's not entirely correct.
Yeah, it has to do with the mom being because if the baby was a high metabolizer, then the baby would clear it quickly.
Right, they would have lower doses.
It refers to the mom being.
It's the mom being. That's right. Yeah. And I think in the next 10, 20, 30 years, it'll be one of the things that we routinely test. So we'll know if you're an ultra rapid metabolizer. Mm-hmm. We're going to have more targeted therapies, medications based on your genetics, because this is something people have known for a long time. It's just a matter of knowing how to test people easily and cheaply. Alcohol, just a quick note on alcohol. I actually had a mom the other day who was talking about only breastfeeding for a few months, and I forget how it came up. I said, she was like, well, I want to go to have my coffee. I said, well, you can have some, or my Red Bull. And I said, well, you can have some caffeine. It's okay. And breastfeed. I said, you can even have a glass of wine or a beer every now and then. And she's like, really? And I'm like, yes, really. And so, I think we forget that. And even in the lay population, this mom was going to breastfeed her child for 4 months so she could go back to Red Bull and her glasses of wine. And I said, no, you can do that. Don't have 3 or 4 Red Bulls, but you can have, a half one or a cup of coffee or so. But alcohol passes freely between the serum and the breast milk, so you don't have to pump and dump. Okay, so 1 glass of wine or beer on occasion is considered okay. More than 2 drinks a day, we basically say no. And the peak levels are 30 to 60 minutes after a drink, so the common wisdom is have your glass of wine while you're breastfeeding your baby, knowing that it's going to peak 30 to 60 minutes later, and then it's going to be another 2 hours or so before you breastfeed again. So staying from breastfeeding for 2 hours per drink, but again, that's about the time you have, even if you're breastfeeding, even if it's the baby's just born, or until you no longer feel the effects of the alcohol, because again, it's what's in your serum is what's in the milk. And by the way, alcohol decreases milk supply, even beer. That's a wives' tale.
Darn.
Yeah, it's not going to work. So what do you do if you're not sure what to do? Well, you err on the side of letting the mother breastfeed. And again, this isn't a postpartum. I'm talking about like right after the baby's born. Let her know the plan might change, okay? If we get those records from wherever you're from and they show that you've been positive all along, we're gonna say no. Or, you know, after we've had some time to do more thorough research, if we decided that, hey, now we feel like this is more of a concern, we're gonna say no. But, you know, especially for nurses, this is helpful to say, hey, it's 2 in the morning, mom just gave birth, you're not sure. If it's you know, if you know mom was positive for cocaine, just say no. Just say no. But if it's a fuzzy situation, go ahead and allow her to breastfeed, but tell her, we're letting you do this, or we're encouraging it right now, knowing that we're gonna look into this more and we may make a different decision later. And then of course, document. Provider counseling, again, I hit home on this a lot because I think it's one of the areas that most of us are, I don't know, we're a little bit weak in this. So just talking to moms about your concerns is really important. And, you know, I find very few mothers who, if I talk to them in quite a bit of detail and really sit down, that they won't understand it. And I've had mom after mom after mom tell me, whether we're talking about marijuana or opiates or whatever, how appreciative they are of my taking the time to talk to them about what my concerns are and why I think yes or no. So, and remind mom, you know, if she starts using more, she may be impaired in her ability to care for her infant. The baby might have trouble sleeping, or they might have, you know, they might become too sleepy or not sleepy enough. They might have long-term effects on their development, and we just don't know, marijuana being a good example. And then, of course, you know, legal repercussions if the baby's found to be positive. We had a baby just last week who, quote unquote, accidentally ingested methadone that was in a sippy cup. Now that wasn't breast milk, but you know, it's not good when you find that. So what if this mom was hepatitis C positive? Can she still breastfeed?
Yes.
Yeah. So now we're going to switch over to contraindications, dealing more with diseases and conditions. So I have the CDC site here because I love the CDC site. I think the CDC site is really, really helpful. It's very clear, and you can click on specific illnesses that you might have questions for. And it's, again, you can see it's a very short list. So true contraindications to breastfeeding are really limited. So infant conditions is pretty much classic galactosemia. And I add in the but not the Duarte variant because I had this recently where I thought, oh my God, the baby's sibling had galactosemia. We're worried about it with this baby. Can they breastfeed? I talked to the geneticists and they said, no, it should be fine. The sibling had the Duarte variant, and if this baby has it, that'll be what they have too. And they still make some of the enzymes to break down the galactose, and it's fine for them to breastfeed. And that is ultimately what the baby had, and it was fine. Maternal conditions, HIV, caveat, if you're practicing in Africa where a mom does not have access to antiretrovirals, etc., actually breastfeeding is indicated and is going to be more likely to actually prevent the baby from getting HIV than not breastfeeding, in part because you don't have to worry about contaminated water and, you know, leaky membranes. The real big thing about HIV is when you're most likely to transmit it is when you're doing cow's milk and the breast milk, because the cow's milk tends to you know, add a little inflammation to the intestines and more likely to have things passing, you know, through the, you know, the intestines to the blood. But in America, we have antiretrovirals, we have formula, the risk outweigh the benefits. HTLV types 1 and 2, which are causes of leukemia, very much transmitted through the breast milk, and untreated brucellosis. This is not a long list. This is a very short list. Conditions limiting breastfeeding, PKU, they need to have phenylalanine-free formula combined with the breast milk. Other inborn errors in metabolism, again, they might require mixing, but they can usually breastfeed as well. They just might have to get a special formula. And you're going to monitor and you're going to talk to your friendly geneticist. You're not going to do this on your own. Conditions that are not contraindications to breastfeeding. Cow's milk protein, other food allergies. You can do an elimination diet for mom if she's willing. Hyperbilirubinemia, when I started practicing, every baby who was getting phototherapy automatically got formula. That is not required. In fact, it's rarely going to be required that a baby get any formula if they're under phototherapy. You're going to consider if they've got extreme weight loss, if they're really dehydrated, or if their hyperbilirubinemia is so bad that they're going to get, you know, IVIG or exchange transfusion. Although, frankly, these babies are going to be in the NICU and they're going to be getting IV fluid, so they're not even going to be getting formula. Thrush, not a contraindication. treat mom's breast and the baby's mouth simultaneously, sterilize the bottles. For mom, conditions that may require temporary separation of the mother and baby. These are the kinds of things that on a case-by-case basis you're going to go back and look up. So, I mean, I wouldn't expect anybody to memorize these. You just would know in the back of your head, oh, I've heard somewhere, I'm going to look this up. So if you have active infectious untreated tuberculosis, so in other words, the mom is actually coughing, mom can give express breast milk to the baby. But you want to keep mom and baby away because it's so contagious. After 2 weeks of treatment, mom can resume direct breastfeeding, and when she's no longer infectious. Chickenpox, varicella, 5 days before, up to 2 days after delivery. A little confused when I was reading about it. Express breast milk could definitely be given to the baby. So again, baby can get mama's milk in both these cases. In some areas it just says if it's 5 days before, 2 days after. Others say you can resume breastfeeding when the lesions have crusted over. So the way I've interpreted it is mom doesn't have any lesions that are not crusted over, and she's not in this window of period of time. Have I ever actually had this come up? No, but it could. H1N1, this was a big deal when we had H1N1 before we had the vaccine. We were going crazy about this, and so what they said was separate mom and baby and express breast milk, and that's what we did. Maternal conditions requiring baby to avoid direct breastfeeding on the affected breast only. So if you have an active herpes simplex lesion on the breast, she can breastfeed on the other side, and she can get express breast milk from either side. Hepatitis C positive mom with cracked or bleeding nipples. This is kind of theoretical. There hasn't actually, to my knowledge, been any documented transmission of Hep C. So some sources will simply say Hep C is not a contraindication of breastfeeding ever. The way we do it is if you have Hep C and mom has cracked bleeding nipples, we're going to have mom breastfeed on the other side. And we're not going to have her give her milk from that side, even, we're going to say pump and dump from the affected side till it's healed. I've seen a lot of moms who are Hep C positive. I've actually never had a mom who had cracked and bleeding nipples to the point where we had to do this, but it's in the back of our mind.
Sorry, it's Sophie. I just wanted to add one thing that I will say that because Hep C is pretty prominent in our state, this is something that I bump into with other practitioners. It's like a miseducation point that I see all the time. So I just wanted to reiterate that you will probably find a lot of uneducated providers about this specific issue who are telling people to stop breastfeeding.
Yeah, thank you, Sophie. I'm glad you said that because it's more powerful coming from somebody besides me, and that's exactly right. When I started practice here, we did not encourage / permit moms to breastfeed if they were Hep C positive. That is how much we've changed just in 16 years. So, and this is one of the most commonly, one of the most common misperceptions. So thank you. Whoops.
Sophie, I just want to do a quick time check. We've got about 5 minutes.
Oh, perfect. So this is perfect. We're going to be done just in time.
Okay.
So maternal conditions that are not contraindications to breastfeeding. Hepatitis B. Not going to see it that often, but we see it several times a year. Not a contraindication to breastfeeding. Now you're going to want to give that baby their Hep B shot vaccine within 12 hours. You're going to want H big, but mom can breastfeed. Even if you weren't doing those things, mom could breastfeed. Hepatitis C, again, except for those limited instances. CMV, I've heard this one quite a lot. Have you heard about that as well, Sophie? I've had people question.
I haven't bumped into that recently. I honestly, I haven't seen that many CMV moms. I have one.
I haven't either, but I have heard, I guess I haven't seen it, but I've heard of people saying or thinking that CMV was a contraindication, and it's not. Again, the yeast infection, I'm just taking it on the mom side versus the baby side. So if mom has yeast in her breast, again, you're going to treat mom's breast and baby's mouth simultaneously, sterilize the bottles. I like gentian violet the best because it's really a pain to do a medicine 4 times a day in your baby's mouth or 4 times a day on your breast. And gentian violet, everybody's purple. It works awesome. I'll send them home with a little bit and say, repeat this in 3 days on your breast and the baby's mouth. They just say, get those old bras and t-shirts you don't care about. It really makes life much simpler. And the last thing you need in a new breastfeeding mom's life is for anything to be complicated. Mastitis, totally can keep breastfeeding. In fact, it helps. Anything that drains that breast is going to help. The caveat they said is the baby shouldn't ingest the drainage from the abscess. I got mastitis, and I'm going to give personal health information, but it's okay, Kevin, because I don't care if anybody knows this. I had mastitis when one of my kids was 2, and I didn't know this. And God, she breastfed on that side, and she probably got some pus. She's fine. She's not. Exposure to environmental contaminants. In most cases, levels in breast milk are lower than levels in cow's milk. It's okay. You will hear people. I've had people stand up in lectures at grand rounds. Well, mom's milk has all these contaminants and everything. It's like, yes, and so does the cow's milk. Cow's breast milk has it as well. Human milk is no, we have the same exposures as they do, except for in the case where you've got a mom who's like, say, in the hospital because she's currently toxic, has an acute exposure with acute signs and symptoms, and maybe at that point you would want her to not breastfeed. But for the most point, it's totally fine.
Quick question,
Yeah.
What is CMV?
CMV is cytomegalovirus.
Oh, okay.
And it's just a very, very common virus. Very common. Smoking is not a contraindication. You all know that. Encouraged to cut down or quit. Tell them not to smoke around the baby. But if she can't quit smoking, tell them baby's going to need the extra protection from breast milk to help combat the respiratory infections whose risk are going to go up with the smoking, right? You want to try to offset that risk. So smoke after nursing to minimize the transfer of nicotine. Don't smoke near the baby. And the most important thing is if you've got a mom who's smoking, I always go out of my way to talk to those moms about not bed sharing specifically. And that's a whole other topic, but that's the one time I really try hard to do above and beyond what I normally do and really say specifically to that mom, you may not bed share. Breast augmentation or reduction, neither one are contraindications. Rarely going to be a problem with implants. And silicone is safe. That was a question that has been raised in the past. Breast reduction can lead to decreased milk production. So if you've got a mom who had augmentation or reduction, we always consult lactation for those moms, always. And we always have them follow with lactation so we can keep a close eye on milk supply and monitor baby's growth. Vaccines, there's only 2 live vaccines that shouldn't be given to moms, neither of which we give. Smallpox, yellow fever. Yellow fever, you could have a mom traveling. So all other vaccines are acceptable, including rabies vaccine. So a few take-home points. Very few medications can't be taken while breastfeeding. And even those ones we talked about, codeine and hydrocodone, even those are not absolute contraindications. There are a lot of resources out there to consult if you're unsure. LactMed and Hale being number 1. Your friendly lactation specialist or Dr. Peterson or myself being, or other like-minded folks being other people you can talk to. Having a hospital-specific breastfeeding and substance abuse policy is super, super helpful. I encourage you to do that if you don't already have one in your hospital. And again, there are very, very few true contraindications to breastfeeding. So I have a lot of resources here. I would point out, the AAP Committee on Drugs, transfer of drugs is really helpful. Again, LactMed. This Lawrence doctor had a really nice long article about contraindications that'll confuse you, but if you really want to get into the depths, you can go there. It's not. And any questions? Cute pictures are mandatory with breastfeeding talks. Thank you very much, everybody. I really appreciate it. And if you have questions now, I would love to answer them, and I would also be delighted to answer questions by email, etc.
All right. And if we don't have any questions, Dr. Sebesta, thank you so much for your time today. And thank you, everyone, for your time. And as I mentioned before, if I have your email address, I'll be emailing you a survey. Please take a couple minutes to fill that out. And thank you for joining us today, and have a great day.
Thank you, Emily. Thanks, everybody.
Thank you.